Good morning, everybody, and welcome to this morning's webinar from Interacoustics Academy on the role of vestibular diagnostic test in the management of dizziness patients. My name is Darren Whelan. I'm an international clinical trainer, and I joined Interacoustics Academy August last year, so still relatively new, following over a 25-year career working as a clinical audiologist and holding several senior clinical positions in the National Health Service in the United Kingdom. In particular, my clinical interests were with diagnostic audiology and largely looking at assessing vestibular patients and patients presenting with dizziness to a large ENT and neuro-otology clinic. This morning's presentation is really looking at what we already know with regards to vestibular diagnostic tests, and to think of these again in terms of what they tell us in relation to the peripheral vestibular lesion, but then also consider what those findings might actually mean when we start to think about vestibular pathology presenting with different patterns of this is something that would potentially have consequences in relation to the management of those patients once the lesion has been identified. In particular, this morning's webinar, I would like to focus more looking at unilateral peripheral vestibular pathology. Vestibular pathology, as we know, can come in many different forms, and the area is very broad, but our most prevalent presentation is unilateral. And so I'd like to focus on that area so that we can examine and delve a bit deeper into what our test findings tell us about these unilateral peripheral vestibular pathologies, and what we then can consider in relation to the evidence that we already know and the consequences then of potentially managing this patient group in the future. It's always nice when we come back and look at some of the way in which we're currently working clinically to think about how things have developed over time. I have quite a passion for knowing where we came from in terms of some of the testing that we currently undertake, and to be able to then place that into context to the journey that our field of science has gone on. I'm going to start at 1907. In actual fact, vestibular science extends a little bit further than that. Some of the earlier reports in terms of the first description of the vestibular labyrinth are down into the 1600s, so the 17th century. But more modern vestibular science, I think we can almost accredit to someone who's very familiar to us, which is Bharani. Now, back in 1907, Bharani took something that was already a little bit known, in that we knew prior to Bharani that irrigating an ear can induce nystagmus. However, Bharani, whilst taking out some impacted wax, discovered that he could see these eye movements, so much so that this was so groundbreaking that he was awarded the Nobel Prize for it in 1914. Moving a little bit further on, we start then to get some real interest in diagnostic vestibular work and thinking about how we then can capture these eye movements. And as we start to move between the 1920s and 30s, the development, really the birthplace of what we then knew as electronystagmography started to take place. These recordings, these ocular recordings of eye movement, to allow us then to capture what has actually occurred when we've stimulated the vestibular system. And as we then move along that timeline, we start to get to the 1940s, where Fitzgerald starts to come up with bithermal chloric assessments, and certainly then Jonkeys and the like develop the way in which we then start to look at hyperfunction and directional preponderance, measures that we are still using today with great reliability. And as we move then towards
the 50s, 60s and 1970s, obviously this is a new and expanding area. We're starting to see, from a vestibular perspective, evoked potentials taking some significant leaps, looking at ECG to look at the function within the peripheral end organ. And we move then obviously towards much more ENG recording using surface electrodes and measuring the cornea potentials. And then as we move onwards from the 1980s, we start to get into more familiar territory. We now start to see video nystagmography becoming more prevalent, and the recording now without electrodes of actual physical eye movement really moves the science quite a significant period forward, both in the accuracy of what we can see and record, but also the ability then to actually record those to such an extent where we can share those amongst ourselves, amongst our peers, and to be able to go back and review some of these eye movements in much more detail. And then we start to move into more modern times now, and it seems strange sometimes to talk about the 1990s as modern times, but in actual fact, in vestibular science, techniques that we're just starting to see develop and being used much more clinically have actually had their first clinical reveal, if you like, often 15 to 20 years previously, sometimes a little bit more. So cervical VEMP certainly started to become much more a clinically viable test in the early 1990s, and then we moved a little bit further forward in time and started to look then at ocular VEMP, and the research coming out of those labs started to become very interesting to us. And now we're really on the cusp of modern life into 2013s, and seeing the development now of video head impulse testing, a test which the head impulse test, by Hermagli, developed with Curthoys around in the 1980s, looking at these saccadic eye corrections that allowed the identification of peripheral vestibular pathology. But obviously the capturing of some of these very quick, almost compensated lesions really became quite elusive to us until we had the technology available to us to record those, as we do now, very accurately within thousandths of a second. And that really was quite a significant step forward in terms of opening up the potential of assessing much more quantitatively the function of these peripheral vestibular end organs through the measurement of the vestibular ocular reflex. Along with all of these new developments, we had to then change some of our thinking, because as new evidence becomes available to us, new scientific approaches, we could easily say we have 10 elements of peripheral vestibular function that we can examine, which up until relatively recently was a lot more difficult to ascertain. So if we take it in terms of just looking at semicircular canal function, through the use of measuring VOR responses, we know that we have 6 semicircular canals. If we then add in the otolith function, so looking at the utricle through oVEMP and the saccule through cVEMP, that takes us up to 10 features of that organ that we can look at. On top of that, we could argue, in actual fact, we can now differentiate between superior vestibular nerve issues and inferior vestibular nerve issues. So that's actually an additional insight into what the peripheral vestibular function is actually doing in some of the lesions that patients that we see experience. And now our newer developments are starting to use tests that allow us to really do some almost bedside testing, some very quick bedside testing with great accuracy, and thinking of things like the virtual subjective visual vertical test, and being able to look now then at utricular dysfunction in patients, and knowing that vestibular dysfunction in the utricular system can often lead to issues around postural instability. And we'll talk a little bit more about what the different features could be with these peripheral vestibular identities as we go through this morning's presentation. To capture almost in a quick snapshot this area now of looking at peripheral vestibular diagnostic testing, here we have our semicircular canals, our saccule and utricular system, and this 10 touch point approach of seeing that we can actually now look much deeper into what we may see in terms of pathology, and understanding then how this is having an impact functionally on an individual, and what we might then consider in terms of management of that moving forwards. So this may be a slide that some of you have seen in the past, and it's something I think is almost useful for us to keep coming and revisiting, because now we can see overlaid onto our peripheral vestibular organ the tests and areas that they allow us to examine. So with vEMP, as we said, we're looking at the otolith, and we have subjective visual vertical there capturing the utricular. We've got ECOG, a good long-standing test, and looking at some of the endolymphatic changes in that system, and then we've got our VHIT, VNG and chloric looking at obviously the other semicircular canal functions. So thinking again just at the peripheral end organ, with our chloric we have been for a very long time looking at hyperfunction within that horizontal semicircular canal, allowing us to capture some significant differences in terms of the sensitivity of these two end organs. Still remains very much the gold standard in terms of individual ear assessment, because it's the one test that we have with the peripheral vestibular end organ looking at this VOR response that allows us to independently test a right or a left ear on its own. And then looking at more than at these semicircular canal functions, our VHIT allows us now then to capture, additional to the horizontal lateral semicircular canal function, the anterior and also the posterior function of the semicircular canal. So much greater insight into the angular VOR response than we have previously been able to utilize. What does the literature tell us then about some of these tests that we have performed? We know that the chloric test has been well received in terms of a lateral semicircular canal function test. It does allow us to create this baseline for vestibular function. So we can look at changes over time with progression in disease or degeneration of the system. It allows us to examine the very low frequency component of peripheral vestibular function. Also, we can individually assess the peripheral vestibular system. So in terms of its contribution, it still has a very significant impact in terms of our overall assessment of vestibular function in patients presenting with dizziness. The VHIT, which is our newer technology clinically, allows us, as we've said, to measure all of the 6 semicircular canal functions through capturing VOR responses. We could use this as a triaging tool. For those that are familiar with VHIT, it's a test that can be conducted quite reliably within 10 minutes, often a little bit quicker than that when you become much more familiar with the test. So it can be used to direct yourself in terms of how you may then want to manage your patient for further testing going forwards. We can actually use VHIT, and some very useful research has come out from Australia with Curthoys and the team in Sydney, looking at measuring for vestibular compensation with VHIT. Now we can do that in one of two ways. We could look at the change in saccade and the placement of saccade over time, and also with a newer SHIMP test looking at residual vestibular function as well. Obviously head impulse testing is very much been used in the emergency rooms and accident emergency, if you're from the UK, rooms, to differentiate between patients presenting with acute dizziness, whether it's a stroke or an acute vestibular syndrome such as a vestibular neuronitis. Again, we can use these as creating a baseline, so we could look at either improvement, as we've said, with compensation, seeing saccades move maybe from an overt to a covert saccade, or in actual fact looking at progressive disease and seeing how that might be changing the vestibular function over time also. Now moving on to our otolith organs. So here we have the utricular system, well captured diagnostically using the oVEMP measurement, and we have the saccular response again encapsulated within the cervical vent measurement. If we just have a look then again at what the pathways are through some of these measurements, just to refresh our memories. So for a cervical vent measurement, something that now had some clinical utility for the best part certainly of over 10 to 15 years. What we're doing here is we're measuring saccular responses by stimulating the peripheral end organ, and we can do that by air conduction or bone conduction, but we're stimulating the organ and it's coming up the saccule, in through the inferior vestibular nerve pathways we can see here, through the vestibular nucleus, and then down our vestibular spinal tract through the spinal accessory, and then we're measuring it from those big, large sternocleidomastoid mastoid muscles in the neck. So these great rotators do give us a great insight into the saccular function. It's ipsilateral in nature, so in other words, if we're stimulating the right side, we're measuring from the right sternocleidomastoid mastoid muscle. It's inhibitory, so in actual fact, as we know with cVEMP, we need to get the tonic level of muscle activity sufficiently raised so that we can capture the VCR reflex as it relaxes myogenically the muscle due to the stimulation. Now with oVEMP, what we have again is stimulation either acoustically or by vibration, and that is a slightly different response. So if we're looking at the left utricular, and again the pathway here is through the superior vestibular nerve up to the vestibular nuclei, and then down through into the oculomotor nerves to be measured on the opposite eye. So if we stimulate here, as we can see in our diagram, the left utricle, we're actually measuring this from the inferior oblique muscle, which is just tucked underneath the right eye under the orbit. So this in actual fact is a bilateral crossed response, different to the cVEMP in the sense that it's excitatory in nature. Smaller responses when we record them because we're recording from much smaller muscles also. The question that often gets asked is why do we have different measures? If we're looking at VEMP measurements, surely sometimes maybe the question may be posed to us, maybe one otolith test is sufficient. If I measure the saccule, can't that tell me everything that I maybe need to know about the otolith system? Well, as we've just shown with our diagrams earlier, the issue that we have with the systems in the vestibular system, and the thing that probably captures us all and keeps our passion, is that it has quite a bit of different innovation. So with our oVEMP, what we're doing is we're capturing that utricular function. So that's only part of the otolith function, and we're capturing it through the superior vestibular nerve. It gives us a bit of an almost a top deck look into the otolith system. Whereas with cVEMP, what we have there is the saccular response with the inferior vestibular nerve. So much more into what often can get referred to anecdotally in the literature as the basement. So we're actually looking into the lower floor then of the otolith system. So two very different systems within the same organ that we utilize also differently in terms of what we then use for balance control, and we'll talk a little bit more about that in a moment. You can see there just in my diagram the innervation of the nerve endings going to the separate portions of the otolith organ. So again, going back and thinking what the literature might tell us in relation to these tests that we undertake. Well, we've expressed that the utricular function can be captured through the oVEMP measurement. We can look at vestibular neuronitis, and interestingly this is now leading us towards where these vestibular pathologies may possibly have a different identity, in that they don't necessarily always affect the same regions within the peripheral vestibular organ. We can look at things like Meniere's disease and certainly differentiate between definite Meniere's disease or probable Meniere's disease, looking at some of the changes in the cVEMP response for frequency. We can also look at third window phenomena, so more commonly referred to as superior semicircular canal dehiscence. Now has really shown some development as we can use oVEMP clinically much more reliably, and we can now do insights in terms of the amplitude size in oVEMP to allow us to ascertain whether we believe third window effect is occurring. And this actually does become much more reliable in terms of identifying the condition even beyond good CT scanning. CT scanning, even with very good planeal scans, often struggles to know the difference between about 0.5 millimeters, 0.4 millimeters of bone thickness, whereas oVEMP and cVEMP actually can reliably predict that third window effect much more commonly. And then we've got saccular function. So Again, saccular function tends to be something that we look at much more thinking of endolymphatic hydrops and the changes within that system, and allowing us then to capture some insight into what the behaviour may be with patients that we think are expressing with Meniere's disease. And that does become quite important because we've seen in the literature some overlap between patients that come to us with potentially migraine-associated vertigo, which can have peripheral, what appear to be peripheral symptoms, and could be considered to have Meniere's disease. But when we go and test a little bit further, we actually find that the driver behind some of the symptoms are more the migraine instigator than the actual peripheral end organ being at fault. We've spoken about the superior vestibular nerve. We can come back and we can look at these, as we referred to before, changes over time, these degenerations of progressive conditions such as the vestibular schwannoma, and we can make decisions around potentially for our ENT surgeons what surgical approach to maybe use. Is there any residual function? What's the hearing like? What's the vestibular function like? Can we then look at maybe even doing some prehab vestibular rehabilitation on patient going forwards for vestibular schwannoma to already prepare them for the eventual maybe vestibular loss that they're going to encounter after removal. And now we have our inferior vestibular nerve also just sneaking in the bottom there to remind us that it has an important feature within the vestibular sensory system. So that really brings us now into the real main part of this presentation. We've re-examined the diagnostic tests. We've considered them in light of where they give us some really valuable information about the peripheral end organ. The question now is, well, what does that really mean? If we are saying that we've got lesions with different identities, well, what importance is that to us as clinicians in terms of managing our patients? Well, thinking of semicircular canal function, we know that we've got tests there that allow us to capture that. We have our oVEMP measurements, as we've said, and subjective visual vertical that allows us to look at the otolith system. What that presents to us when we do our testing and gather our data is almost this big, what I almost refer to as the big jigsaw puzzle of potential peripheral vestibular dysfunction. We've talked almost about there being 10 points of touch with these vestibular sensory systems. What does that then mean in terms of their presentation? How does that puzzle present itself to us, and what importance would it be in terms of the management? And not to forget there with our inferior vestibular nerve and superior vestibular nerve innervation also. So if we consider semicircular canal involvement, something that we're probably a little bit more comfortable with clinically, these are tests that we have been doing reliably, as we have said, from the 1940s, and we've got good robust evidence to look at vestibular hyperfunction and the treatment of hyperfunction also. And then we've got potential utricular involvement in a peripheral vestibular pathology, also saccular involvement. With our semicircular canal involvement, we could have superior vestibular nerve and or inferior vestibular nerve involvement as well. We could add that into a utricular involvement, so we could have patients that present to us with a semicircular canal hyperfunction, which also then has a utricular hyperfunction. So again, that would involve our superior vestibular nerve. We could have a patient that presents to us with semicircular canal pathology, but has a saccular involvement as well. And that again would then include the inferior vestibular nerve. Or in fact, we could have somebody which has complete unilateral vestibular hyperfunction, who then has lost semicircular canal function, utricular function, and saccular function. And that's where things now start to become interesting, because just there in one slide, we've actually captured pathology that maybe in the literature, and we'll talk a little bit more about that in a while, would be described as unilateral vestibular hyperfunction. But I think arguably we might say, well, a semicircular canal change would be potentially different to one that also then presents with some otolith features. And if the otolith system is completely involved, then we may be seeing a patient that's presenting from a functional perspective and a symptomatic perspective differently than maybe somebody who has a lateral canal, semicircular canal hyperfunction. So in terms of how we then look at our patients, it's always worth having a think around how our patients report to us. So their primary complaint would be dizziness, and we'd spend some time on that reported history. I think one of the great things that I get some pleasure from in terms of seeing vestibular patients is this art form almost of this forensic approach to investigating dizziness and balance. And through our reported history and interview with the patient, we start to get a feel for whether we believe that this has got a vestibular component. And that in itself then can lead us to think of other observations that we may be able to see functionally with the patient if we believe that there is a vestibular component to their reported symptoms. That could be in relation to head or body movements, and certainly to any gait changes or stability or postural control issues that they may be describing to us. That then, as a clinician, leads us to start thinking about vestibular investigations. We have the consideration then of what assessments to undertake to establish that we do have the presence or the absence of vestibular involvement in this symptom presentation from our patient. Once we have done our tests and we've clarified the function and status of that vestibular end organ, we're then into the realm of management. And having identified a vestibular dysfunction, who would benefit from management of that function and how that management be undertaken? So again, just thinking, it's almost, these light bulb moments that we sometimes can have. If we're looking at vestibular function and more importantly, looking for dysfunction within that system, what assessments do we need to undertake? Is it sufficient to do a chloric assessment? Do we need to do V-hit assessments? When would we use otolith assessments? Do we do them all? Well, I think that's an interesting debate, and I think different clinicians would have different ideas around that. But certainly what we could say from a holistic perspective is if we believe somebody has presented with vestibular dysfunction, how can we then investigate that thoroughly? How can we use our forensic approach to ascertain that actually, yes, there is a functional change here that we can then look at managing as a vestibular condition? Or no, the function is actually okay, therefore this may be presenting from a different pathology site. So once we've established our identity and location, it then tells us what we need to think about in terms of maybe appropriate management. So here we've got a little example, and I'm not going to spend a lot of time doing lots of different examples, as much as we could do this for a very long time, but just to encapsulate some of the essence of what we've been speaking about. So here we have a patient that's arrived at our clinic. His name's Sebastian, and he's presented to us with some dizziness. So straight away we're trying to then start to think about what Sebastian's problems may be in relation to his dizziness. He's describing to us this sudden onset of dizziness, and he's describing it as a true rotational dizziness. He's saying that the room was spinning. He experienced this spinning to some degree for almost 48 hours. Once that 48 hours were over, most of which he probably spent in bed, he then was moving around the home and increasing his activity, still feeling somewhat unwell for several days afterwards. Now he's attended our clinic and he's generally functioning very, very well. However, his main complaint is that he's feeling some dizziness with very quick head movements. He's returned to work, but he's limiting his activities. So these are often patients that we do see sometimes coming in. They have the characteristic turning of the whole body and head movement in clinic, which automatically suggests to us that maybe there is a vestibular component that they're trying not to trigger by not moving the head and triggering a very strong angular response through the semicircular canals. So with Sebastian in clinic, I guess it's time for us to start doing some assessments. So we take him into our clinic room. I'm just going to present some here, not necessarily in the order that I would undertake them, but to use them for illustrative purposes. So here we're examining his left ear, and we've done some VEMP measurements, and we've got satisfactory cVEMP and oVEMP. So At this point in time, we're quite happy that his otolith system appears to be intact and functioning satisfactory. We do our VNG, and VNG with gaze and oculomotor has all been reported as satisfactory, and his Dixell-Pike positioning testing is also negative for BPPV. So we've ruled out any dynamic issue with otoliths being in the wrong place in that peripheral vestibular end organ. We've undertaken our chloric assessment, and actually that's provided some useful insight. We've got a left unilateral weakness of over 40%. So that's telling us that we have got some change that's occurred on this left ear. And at this point in time, we've got the lateral and superior vestibular nerve involved. One might say, well, we've identified a unilateral peripheral vestibular lesion now. This fits with some of the symptoms that your patient Sebastian's presented with. Surely this is a point where you could now maybe start thinking of a management strategy. And that is not an unreasonable rationale to have. However, what we don't really know is it just the superior vestibular nerve from the semicircular canals that's been involved, or do we have other semicircular canal involvement as well? So we can undertake our V-hit. Actually, in this case, our V-hit has confirmed with the chloric test. We can see here that our lateral left has an abnormal response, so he's got some saccades correcting for the dysfunction that's occurring in the left peripheral system. But we've now reassured ourselves that our RALP and our LARP responses are normal, so there are no catch-up saccades on either the right anterior or left posterior VOR semicircular canal response, or the left anterior and the right posterior semicircular canal VOR responses. So in this case, if we kind of then look at that and take this forensic approach, what's it told us about his system? Well, we've established that there's a left hyperfunction. We have got some evidence of semicircular canal involvement, and we know that the lateral semicircular canal has some hyperfunction, but we've established that the anterior and the posterior semicircular canal on this left ear are functioning satisfactory. We know through our oVEMP responses that the utricular system is fine, and also we've through cVEMP looked at the saccular system, and we know that's fine also. So in actual fact here, we've got quite a lot of residual peripheral vestibular function still remaining for our patient. And this now we can look at as a left lateral semicircular canal hyperfunction that in actual fact hasn't extended so much into the superior vestibular nerve, because we know that we've got utricular function and anterior semicircular canal function that's intact. So this may be just affecting into the actual sensory organ itself, or the branch of the superior vestibular nerve as it innervates the lateral semicircular canal. Thankfully on this, we know that if this is a potentially on the superior branch, that sometimes we do see a BPPV presentation, but we've checked out Dixell-Pike, and in Sebastian's case he doesn't have that present. Now let's take another example. So here we have another patient that's arrived at our clinic, and this is Charlotte. So Charlotte's come to us with some dizziness also. So again, we start with our 0.1 reported history. She's also describing some sudden onset of dizziness. However, whilst her dizziness is a true rotational dizziness, it resolves very quickly in real terms, in 4 hours. Not probably very quickly for her when she's experiencing that, but in terms of an actual attack, these are relatively shorter in duration than we may see with a vestibular neuronitis or a labyrinthitis event. She's also telling us she's experiencing some left ear symptoms. In her description, this is an odd sensation within her ear. She's reporting ringing, so we've got tinnitus in there as well, and she's describing some distortion to her hearing, which does resolve within a day or so of having dizziness. Unfortunately for Charlotte, she's actually experiencing much more reoccurrent episodes. In fact, she's had 5 episodes since the first episode that she experienced. This worries her, and it would for patients. This unpredictable nature of symptoms, it doesn't fit well in terms of how we function, work, or other commitments that we might have. So again, in this case, I think it's time to do some assessments for Charlotte. There certainly seems to be some peripheral vestibular pathology associated with this. So let's see where that takes us. So again, Charlotte's told us about our left ear. So we're going to do another examination here. In this case, we're doing some evoked potentials. We've done an oVEMP measurement. That's been satisfactory. We've done a cVEMP measurement. Now, that's given us an asymmetric response. And in fact, on this left side, we've got some frequency tuning. And by that, what we're talking about is that typically we see the largest amplitude responses around 500 hertz. Depending on the age of the patient, you may see a very similar response around 1000 hertz. It's incredibly unusual in satisfactory functioning vestibular system to see reliable responses at frequencies greater than 1000. In Charlotte's case, we've actually measured her relatively close to an episode of her dizziness, and we've had responses we've able to record at 2000 hertz, 3000 hertz, and even 4000 hertz stimulation. That is very much an unusual presentation on cVEMP and does alert us to a peripheral vestibular component affecting the saccular system. In this case, what we've also undertaken is an ECOG. And what her ECOG has actually shown to us is that she's got a large or an increased SPAP area. So again, this now fitting much more with what we consider to be an endolymphatic change in the peripheral organ. We've done some V&G testing, and thankfully that's been quite satisfactory. However, she has got some sensation of dizziness when being laid on her left side. It's nice at this moment just to take a little sidebar and consider that. Positioning testing is also something that we've been doing for a very, very long time, going back and to the Dix and Hallpike articles from the 1940s, 1946, describing how we can measure BPPV changes within the peripheral end organ and look at eye movements. The difficulty that these positioning tests can present with us is that these can be very brief eye movements. Yes, the patient can report feeling dizzy, but really capturing those eye movements is critical to allow us to establish where those otocornea debris particles may be sitting within the organ, and then make decisions about treatment. With the use of V&G, whilst we do positioning, that actually allows us to record those eye movements much more accurately. So we don't have to worry too much around fixating on the patient's eye. We can record it. In fact, we could play that recording back after having done the positioning test to really ascertain our decision around is there BPPV present. Now in Charlotte's case, because we've used V&G, whilst she did report a sensation of dizziness, we've not got any corresponding rotational, torsional eye movement or even horizontal eye movements. So we know that this is a sensation that's probable down to the hyperfunction of the left system, and when we lay her on the left side, it reveals the tonic asymmetry between the two systems, not a BPV presentation. Our chloric response in this case has also shown a hyperfunction, this time just a little bit greater than 30%. Because that's actually only told us about one semicircular canal, we've decided that we're going to go and do some V-hit. Now this is where things become a little bit more interesting. Our V-hit is actually satisfactory for all of the three semicircular canals on this left ear, and would be on the right side because that's the side that's not actually got any pathology. The question would be then, if we'd started with V-hit and V-hit alone, we could have said that actually we can't see any peripheral vestibular change here. But in actual fact, we have to remind ourselves that the chloric assessment and the V-hit assessment are testing the same angular VOR response, but at different frequencies. So we do have presentations that can show hyperfunction, particularly through conditions such as endolymphatic changes in Meniere's disease, that would be more reliably presented within a chloric or a VEMP or an ECOG measurement, but not necessarily, certainly in the earlier portions of the disease progression, on a V-hit assessment. So again, looking at our schematic for these conditions, what we've established is the lateral canal has some hyperfunction, and we've got anterior and posterior being fine through our V-hit. We've established the utricular system is okay through our oVEMP. However, we know that the saccular system appears to have some dysfunction, looking at the tuning and asymmetry effect on the cVEMP. So in this case, we have a lateral semicircular canal hyperfunction, but also has other features that are consistent with definite Meniere's disease. So if we compare this with Sebastian also had a left lateral hyperfunction. However, he didn't have any otolith involvement in his condition. So although the two could theoretically be classified the same, we've seen just in these two examples different identities of pathology and potentially different management strategies to be employed for these two patients. Now, in terms of looking again at our areas of identity, we've got chloric and VHIT that allows us to look at that angular VOR response, and we've got VEMPs looking at the utricular and saccular responses. And also using this forensic approach, we can then infer information in relation to the inferior and superior vestibular nerve innervation of the peripheral vestibular end organ. So the presence of canal, otolith, or canal involvement has actually in research been shown to reflect in the severity of the reported symptoms and reported handicap. And I'll talk a little bit about that in a moment. We've now established that actually peripheral conditions can present with different patterns of lesion. What we need then, I guess, to think about is to place that into context in terms of consideration of peripheral vestibular lesions and how they may be presented to us in clinic. Now, we've got some fairly large studies. I've chosen here Bath et al. In 2000, who looked at a fairly large sample, 812, who presented to clinic. And we can see that of those with the dizziness category in their particular dizzy clinic, greater than 60% had a peripheral vestibular disorder. Now, it would be interesting in this time to look at, of those over 60%, what would have been the patterns of their peripheral vestibular conditions, because I suspect that we would be seeing different patterns of presentation than maybe we might have had insight to in 2000. And again, we can see that there's some central vestibular disorders, some psychogenic disorders, some that fall into the category of being unknown, and that 1 in 10 patients can have symptoms that are very hard to differentiate and to be able to establish a pathology for. And we do have a proportion of patients that unfortunately can present us with peripheral and central conditions affecting their dizziness symptom. Now we're moving a little bit in towards rehabilitation, and I'm not going to spend a lot of time going into the detail of rehabilitation. That's more a separate topic. However, but let's place that into context, because vestibular rehabilitation is something that has developed, again, over pretty much the same amount of time that vestibular assessment has been in the modern era. So we've got really some of the very early work being done by Cawthorne, looking at vestibular disorders and how they could affect their limits of daily living in patients with dizziness. And we're back in the 1944s here, and certainly moving forwards with Cooksey, who published a description of group exercises to help reduce dizziness in persons with vestibular dysfunction. They were looking at head injuries, but that really, I think one could say, is the birthplace of where we now see vestibular rehabilitation and treatment being started. And in fact, it's not unusual that we use modified versions of the Cawthorne-Cooksey exercises in helping patients with compensation and adaptation to vestibular dysfunction, even to this very day. Moving forwards, we've got descriptions through Dix, looking certainly at the physiological and other factors associated with vertigo. And in fact, Dix is really accredited with having possibly the first description of fatigue being reported by patients with vestibular dysfunction, that feeling that patients have of becoming much more tired as a result of the functional change within their peripheral vestibular end organ. And then we come to, I think, probably the birth, if you like, of this combined approach, looking at the work with Herdman and the group from Emory, looking at vestibular rehabilitation and how we can differentiate different tests and treatments and exercises for gaze stability and postural control and gait analysis. And again, first edition of Susan's combined work was 1994. In fact, we're now on the 4th edition in 2014. And if anyone has copies of those books, you'll find that we're now talking of books that are 500-600 pages in size, with many contributions from areas within different disciplines in seeing dizzy patients. So very valuable text to allow us to understand some of the changes and management strategies for patients with dizziness. Interestingly, with vestibular rehabilitation, we have had a lot of work being done over the last 70 or 80 years. However, we've only really got two large systematic reviews that have been undertaken on that. One by the Cochrane group looking at vestibular rehabilitation for unilateral peripheral vestibular dysfunction in the UK, and they've reported a few different versions of that. The most recent is in 2015. And vestibular rehabilitation for peripheral vestibular hyperfunction by the American Physical Therapy Association as well, APTA, and they published their findings in 2016. What these studies actually demonstrated, well, let's take the Cochrane one, for example. Within the Cochrane, they really did a very large systematic review of the current evidence and found 4 real studies that they could include for. So 4 randomized controlled trials. And what those trials allowed them to be able to say is that certainly vestibular rehabilitation improved the subjective reports of dizziness. It increased individuals' participation in life roles, whether that would be working or social events. It improved their walking and balance and vision, so through visual dynamic acuity. However, there is really no consensus within that literature as to what is the best way to treat vestibular hyperfunction. There are methods proposed through, as we've already said, gaze stability, movement desensitization, postural control exercises. However, the consensus doesn't actually sit within the literature as to if you have a patient that presents with this particular pattern, this is the treatment option for them. And I think that comes down to maybe what we've already now identified, in that in actual fact, amongst unilateral peripheral vestibular hyperfunction, we have different facets of presentation. That means that patients may find that some exercises are more successful for them than others. Now, if we want to think about the considerations then in terms of the management, we can take a little bit more of an insight of what is out there, what is the evidence. So using our great friends Google, Scholar and PubMed, we can do very quick searches, and this is often our go-to as clinicians of, well, what is the evidence out there? What can I find? Well, if you do a Google search on vestibular rehabilitation, you'll find almost 62,000 results. So certainly more than you may be able to get through in your 10-minute lunch break when you're trying to really get to the bottom of what is the best strategy for this particular problematic patient. If we go into PubMed and take a slightly more peer-reviewed approach to what's been included and published, we're still at 2,272 results. So still not the shortest reading list that we might come across. If we extend that and say, well, okay, let's call it vestibular retraining therapy. That's VRT is more commonly a term that we're using. We're still at almost 21,000 results in Google Scholar that have been published and are available. We're down to now 20 results on PubMed, so certainly our reading list is becoming a little more manageable. If we then look at vestibular exercises, we can see that here we're almost at 29,000 results and 952 results on PubMed. If we then want to think, well, okay, there's quite a lot of information out there in terms of some of the management, how about assessment? What approach do I take? When do I do a chloric? When do I do a V-hit? When do I do a VEMP? Do I do them all? What would be the best strategy? Not so great news for us there in terms of getting us some clear, definite answers. On Google Scholar, we'll find that presently, and this search was only conducted a couple of days ago, we're almost up to 160,000 results on there in terms of how we might assess the vestibular sensory system. In PubMed, a little bit less, obviously. We're at 1,796, but still a huge body of evidence for us to be considering. I guess our conclusion from this, and it is a little bit of a snapshot just into the degree of information that's out there for us as clinicians, is that there is a lot of information available, but very few published articles have considered the extent of vestibular dysfunction and its subsequent management. Management really always places it in terms of what we consider in relation to the population that we might be seeing. And it's always nice to just take a moment, look at that and the consequences of an aging population. We know that the prevalence of dizziness increases with age, and what we also know now in developed countries and developing countries, our elderly population is growing at a very large rate. So people are living longer. And if we look at some of the census data, just out of interest, at the beginning of the 19th century, we had populations that were living somewhere in the region of about 47 years of age, whereas in the more recent population censuses, the average age is now in the early 80s in terms of life expectancy. So quite a change in the last 100 or so years. But what we can see here, and this is from the Office of National Statistics in the UK, it's their 2017 study, in that we're seeing quite a significant increase between where our proportion of 65-year-olds have been to where they're actually heading in terms of their prediction in terms of population overall. So let's just break that down a little bit further then. And what I've done here is I'm looking at UK adults, but this could be extrapolated to any European or developed country or developing country globally. In 2004, the UK population was somewhere around about 60 million people, which had then 15.9 million people of the age of 65 and over. As we move forward to 2014, that percentage, number, because the percentage is increasing, of 65-year-olds and older is now at almost 18 million. If we come now to 2014, and now we're into the projections that have been made in relation to population growth, we're at almost 20 million. So within a very relatively short space of time from our first snapshot in 2004, we've increased that population by a good 4 million additional people of the age 65 and over. As we move to 2034, this population now is 71 million for the UK as a whole. So a percentage of that as 65-year-olds would be over 23 million. And then, in 2039, where the predictions sort of start to end, we're looking at populations of almost 24.3 million people of the age 65 and older in the UK. So quite a significant increase in a relatively short period of time. So you may be saying, well, that's all very interesting and it's a nice line and we can see that older people are living for longer and they're becoming a bigger proportion of our population. What does that really mean? Well, what we know that means is that the number of patients presenting with dizziness as a percentage means that the number is going to go up. And if we look at that in terms of population, then we're expecting to see a 75% increase just on these extrapolated figures in terms of the number of patients presenting with dizziness. So that really gives us a quite a sensible reminder that the diagnostic testing it becomes much more critical, because if we want to successfully manage these patients, identifying peripheral vestibular lesions and also then having management strategies that are going to be effective for this aging population, we need to be able to do this very efficiently, because the number of patients going to be presenting to us is increasing. So if we think an approximation, and obviously it changes with age, and I'll show that in a moment, of 30% of the population over, say, 65 will present with dizziness in some form, that is by 2013 almost 5 million people presenting in the UK with dizziness. So that's quite a stark reminder that in actual fact, in terms of the demand on our clinical services, the demands in terms of identification of dizziness disorders, and more importantly, if we then think of the management, the reduction of falls potentially in that age group and the comorbidity issues that can be associated with subsequent falls, loss of independence, the societal change, it's huge. This is really a huge area in terms of consideration in the future. Looking now as we come towards the end of my presentation, some of the population considerations, as we get into the 80th decades and above, we're almost at 40% of patients will present with some form of dizziness. It's likely, as we know from the literature, that patients within this age group could have 2-3 competing pathologies present, and really then it's our diagnostic testing that we need to sharpen to establish, is there a peripheral vestibular component to this? If there is, how do we manage that? Because we've got earlier studies that have looked at the risk of falling is far greater in those of that age range with a vestibular pathology than those without. So, coming now towards the close here, we've got clinical decision making that we're doing all of the time, but really now it's about the integration of results from our test battery, from our assessment strategy, and how we interpret those in relation to the management of our patients. Let me just share with you a little bit more up-to-date literature in relation to particularly otolith involvement. I think it would be not unreasonable to say that otolith dysfunction has been an area that we haven't investigated as thoroughly in the literature, and there are reasons for that in relation to the technologies that have been available. But I think if we just look at some of the studies that have been conducted in relation to this, it gives us a little bit of insight. So in this study here is looking at the otolith dysfunction and the influence of outcome in vestibular rehabilitation. This was done by Murray et al. In 2010. And what their findings was that, yes, otolith involvement actually didn't change or influence the response to rehabilitation of individuals with peripheral vestibular disorder, and that vestibular rehabilitation was associated with improvements in symptoms, the severity of those symptoms, their self-perceived handicap and balance function with otolith dysfunction. What that actually doesn't tell us a huge amount, though, is that whilst the outcome of the treatments that they were providing didn't change whether they had otolith or just semicircular canal or both functions, we don't know what exercises Murray used within that, whether or not otolith was actually given exercises that were different to those for the angular VOR. If we then look at a further study that maybe gives us a bit more insight into this, and this one's by Lisa Farrell, and what her findings have been looking at the symptoms, so more importantly the symptoms that patients presented with canal versus otolith vestibular dysfunction. They used a descriptive symptom index questionnaire, and this differentiated quite clearly symptom changes between patients that only presented with canal and patients that presented with otolith. So in actual fact, whilst Murray looked at the outcome from VR, current vestibular rehabilitation, and what Farrell and Ryan have done was look at the symptoms that the patients reported, and they clearly were able, just on the questionnaires alone, to differentiate between a canal and an otolith disorder just from the symptom severity. And also they looked at dizziness handicap inventory, so these questionnaires give us some very valuable insights into the functional changes, and those had high reports with patients with otolith dysfunction. Mixed presentations of vestibular function can often in the literature get reported as non-classical features, and really this is the idea that patients with otolith dysfunction can describe almost the walking on pillow, the push or pull effects, the postural instability that semicircular canal dysfunction doesn't necessarily present with. And what Farrell and Ryan concluded was that the advances in vestibular function testing procedures has identified different patterns of dysfunction. What we don't have is the management strategies potentially at this time to enable us to ascertain whether we can manage these differently than the current vestibular rehabilitation protocols. A further study was done in 2017. Now, this is by Jung and Lee, and what they looked at was the saccular function and the recovery from subjective sensations of dizziness. And what they found is that patients with absent cVEMP reported a significantly higher DHI score, Dizziness Handicap Inventory Score, they were scoring moderately to severe than those that had intact cVEMP and saccular responses. So again, we're looking at otolith function as part of this clinical presentation that will present differently in patients in terms of their severity and functional change. And they concluded that saccular dysfunction can contribute to a persistent subjective dizziness even after objective measurements of vestibular function have been improved with vestibular rehabilitation. Now, that could be because the management strategy that we've used hasn't helped fully compensate. There are many reasons maybe that the subjective dizziness continues. However, this is something that could have a functional change for that patient going forwards. So if we come back and look at our previous evidence, these papers and systematic reviews have really only looked at unilateral vestibular hyperfunction and studies that have quantified semicircular canal hyperfunction. We don't really have a consensus around the different patterns of whether an otolith contribution, either utricular, saccular, or both, changes the management of our patients. And that really is now bringing us close to a conclusion. So here I'm actually quoting one of my colleagues, Mike Maslin, in this, in terms of saying that methodological research, the methods of the research we use, is frequently paced by the technology that's available. So in other words, our understanding of vestibular unilateral hyperfunction is very much formed around the understanding of semicircular canal hyperfunction, not so much maybe otolith. And there is work out there that's being done currently, but now that we have insights into greater understanding diagnostically, both from an otolith perspective that we can, and the mixed presentation perspective, that might change some aspects of management going forwards. So this increased diagnostic assessment of vestibular disorders has got a technology-driven impetus to it, and it allows us to look at long-standing evidence and to acquire new knowledge and understanding, to be able to modify and improve some of these strategies moving forward. And one would argue that maybe the future identification of vestibular disorders and their subsequent management could be influenced by these insights. I think the work of Farrell and Ryan and Jung and Lee has certainly suggested to us that having a greater understanding of otolith function within our patients presenting with dizziness and functional changes could change how we might then want to manage them going forwards. And if we put that into context with our aging population and the fallers, this is a great challenge for clinicians. And obviously there's within this flow chart the dialogue that us as clinicians and the scientific peer review that we do of things in terms of how we then improve our understanding and our utilization of the clinical tools going forwards. We've got a question here. Let me just... so this has come from Mr. Mukherjee. Thank you for your question. You mentioned that VEMP tuning as a way to look into higher drops. Are there any other test findings? And what about the V-hit chloric pattern? Well, that's a very good, interesting question. And there isn't a straightforward answer to this. Certainly when we look at Meniere's disease and endolymphatic high drops, it really now seems to be at what point in the disease we do some of our assessments. If we're at the early part of the disease and we're close to an episode, we often can capture that through ECOG and look at that SPAP area measurement. And also we can see that sometimes in our cVEMP tuning, and that's really a great insight. Now, the chloric test often will give us a hyperfunction in those cases. That's very valuable. But in fact, what we're probably thinking about in relation to that now is that that's not a semicircular canal hyperfunction. It's an overall hyperfunction due to the dynamic change within the peripheral vestibular system with the endolymphatic high drops. V-hit provides us with some very good higher frequency VOR responses, but can be a little bit inconsistent in Meniere's disease, particularly in the earlier phases. As the disease progresses and we get more permanent changes within the peripheral vestibular system, what we are likely to see is some disruption to the VOR, particularly then with catch-up saccades that are likely to be covert as it compensates. But it's an interesting question, and it's one where it really depends at what phase and point in the disease progression that you're at with high drops and endolymphatic changes.